work at the Department of Acute and Adult Psychiatry at a teaching hospital in a town called Trnava. We are one of the bariatric centers in Slovakia, and that's the reason for the mentioning of bariatric surgery and why I am focusing on it in my presentation. The aim of my presentation is to talk about an escalating global epidemic of overweight and obesity. Obesity, without doubt, represents a great problem worthy of general attention and increased vigilance. The core idea of my speech is to emphasize the devastating effect of obesity on the development and function of human brain, which is already observed in obese children. Because obesity is really not just an aesthetic problem, it has myriad severe health ramifications, both physical and also neuropsychiatric, and that's why I am here. So let me briefly tell you about obesity and about bariatric surgery. The WHO declared that obesity is a global epidemic, and the new term of globesity created to describe the increase of excess weight and obesity in the world population. More than 1.9 billion adults have excess weight, and at least 315 million are clinically obese, as declared by the WHO, and Slovakia is no exception. Obesity exhibits complex associations with mood disorders and affective temperamental dimensions, eating disorders, and also with ADHD-related executive, emotional, and motivational addictive dysfunction. Bariatric surgery is unequivocally the most effective and appropriate way of treatment for this health condition. Bariatric surgery was born in the 1950s at the University of Minnesota. We can talk about an accidental discovery, about serendipity. The first metabolic surgery was the jejunal ileal bypass, performed there by Dr. Arnold J. Kreeman in 1954. The benefits of bariatric surgery include sustained weight loss, resolution of obesity-related comorbidities, also both physical and neuropsychiatric. And bariatric surgery vastly improves, in general, really vastly improves the quality of life of obese patients. The most common type of operation in Slovakia is sleeve gastrectomy. I would like to emphasize the word irreversible because for the patient, there is no way back, but they often do not realize this very important and crucial fact, and the reasons are really different. Who can undergo bariatric surgery? In general, bariatric surgery could be an option for you if your BMI is 40 or higher, or your BMI is 35 to 40, and you have some weight-related problems in which surgically induced weight loss is expected to improve the disorder. And there are failed previous attempts of maintaining weight loss. Bariatric surgery is really one very complicated process, and psychiatrists and psychologists are an important component of this multidisciplinary team preparing the patient for such a serious intervention as bariatric surgery undoubtedly is. Every patient who meets the criteria for undergoing bariatric surgery is required and has a duty to undergo bariatric surgery. Psychiatrist is not the gatekeeper. It's not the one who allows forbids. For us, this pre-surgical mental health assessment is an opportunity to prepare patient for the new realities, for example, and lifelong and serious lifelong changes that occur after this kind of operation. Many of us don't realize that how very important a social background is. In this case, disharmonious social background, because about 20% of partners, regardless of gender, do not agree with the operation. They will sabotage progress, success, and the whole process of bariatric surgery. There is a general consensus that psychiatric diagnosis per se should not be viewed as exclusion criterion. However, literature indicates that patients with 2 or more psychiatric diagnoses are significantly more likely to fail 1 year after the operation in comparison to patients with less than 2 psychiatric diagnoses. Okay, we can go next. Before I get to the psychopathology of bariatric surgery candidates, I would like to underline the biopsychosocial model of obesity, because it's definitely a multifactorial problem with different triggers, psychological problems in their causes and consequences, social factors, social influences and networks, cultural and societal norms and context, and different biological factors and triggers. We should know that adults, especially children, are primed towards eating more. This is great from an evolutionary perspective when we wanted to survive in the time of our ancestors. I like the theory of thrifty genes, for example, but in these days full of readily available junk foods and drink, it is putting our children at a risk of developing obesity. I would like to also underline a very important role of the CNS in the process of eating behavior. Behavior related to food intake is dominantly determined by homeostatic and mesolimbic revert brain areas, or brain area, which depends on the action of dopamine. Dopamine is synthesized and released by neurons located in the ventral tegmental area. This area is also involved in aversion, not just in salience and revert. And there are also some other different parts of human brain, of tricky human brain, which are involved in this important process. Many parts of limbic system involved in emotion, sleep, appetite, memory, learning, behavior, impulsivity, and so on. The whole problem of obesity in our body is inflammation. I would like to point out that adipose tissue is considered the largest human endocrine organ, which performs different important and irreplaceable functions in human body. In this process, there are adipocytes, macrophages of adipose tissue, and gut dysbiases, which occur in the relationship in correlation with obesity. Adipocytes and gut dysbiasis result in the secretion of cytokines and chemokines, which can cross the blood-brain barrier and stimulate microglia, small immune cells of the CNS, which also release pro-inflammatory cytokines. And these pro-inflammatory cytokines cause inflammatory signaling in neighboring neurons, and also insulin and leptin resistance of neurons, and can cause breakdown blood-brain barrier, neuroinflammation, endothelial dysfunction, and so on. And this is the whole problem of inflammation and neuroinflammation, neurodegeneration, and neuroprogression. There are some markable prefrontal cortex anomalies, atrophy of hippocampus in obese patients, cortical degeneration, changes in cortical thickness, hypothalamic gliotic scars, and so on. So why are psychiatrists so interested in bariatric surgery, so focused on obesity? Because this group of patients interested in bariatric surgery show significantly more mental problems. Around 40% of all bariatric surgery patients have at least one psychiatric diagnosis, and up to 70% have a history of psychiatric illness. They show pathological eating behavior, sedentary lifestyle, and worse quality of life, and they experience everyday weight stigma. And that's the possible explanation for the high suicide risk among bariatric surgery candidates and previous suicidal attempts. Among this group of patients, there are really high rates of depression, really high rates of binge eating disorders, for example, really high rates of emotional eating, night eating syndrome, grazing. Typical for this group is severe and subjectively felt loss of control over food intake. Approximately 30% of patients seeking bariatric surgery have some kind of eating pathology. In the population with a BMI over 30, the prevalence of ADHD may be up to 27.4%. On the other hand, the prevalence of obesity is increased by about 70% in adults with ADHD and 40% in children with ADHD. Typical for this group is skipping meals, night eating, emotional eating, binge eating as a part of impulsive personality traits. Typically short sleep duration, and also that leads to night eating, for example, difficulty in planning, emotional dysfunction, inattention. There are high rates of mostly avoidant and antisocial personality disorders. I can't omit the fact that all of our basic behavioral, emotional, and cognitive patterns have been learned at home in our core family. The most risky model for development of obesity is genetic predisposition to obesity, a toxic, stressful environment in which calorie-dense food is readily available and low physical activity. There is a certain possibility that sexual abuse in childhood or some kind of other trauma, for example, sudden loss of parents, lead to pathological eating patterns. Another important part is our sexuality. What differs us from this group? In this kind, this is a part which leads to some kind of possibility that abuse in childhood and, for example, rape in adulthood leads to a possibility that obesity fulfills a kind of protective factors for this kind of patients. I also like the term obese brain, because these structural brain changes lead to a functional changes. Obesity is associated with cognitive impairment in all 6 key domains, including memory and learning, language, complex attention, executive function in general, and perceptual motor control and social cognition. On the other hand, bariatric surgery leads to potential pleiotropic effect, which means regeneration of neuroblasts, changes in connectivity of the brain, restoration of structural abnormalities associated with obesity, improvement of executive functioning, language, mood disorders, and so on. And that's really one very important fact. At the end, I would like to point out that being obese means being really very, very vulnerable in social functioning, interpersonal functioning, healthcare problems. It's a paradoxical state of malnutrition, for example. In fact, the whole problem of chronic inflammation in obesity is reflected in brain health as neuroinflammation. Neuroinflammation is associated with global and focal brain structural and functional alterations. Up to 23% of obese patients have clinically significant cognitive dysfunction in our preoperative screening. Obesity is associated with an increased risk of dementia and other neurodegenerative disorders. One very rare but severe complication of bariatric surgery is Wernicke encephalopathy. We can't forget it, and we should know that there is a risk of Wernicke encephalopathy in patients with prolonged episode of vomiting, with reduced oral intake and presence of any type of neurological symptomatology. And the last thing I would like to emphasize is that bariatric surgery is a tool rather than a cure for their struggle with this very severe problem of obesity. This is because psychopathologic factors often play an important role in the development and consequence of obesity and can have a lifelong effect. And just knowledge about the vicious circle of obesity and its neuropsychiatric complications enables us provide an adequate help for this kind of patients. Thank you very much for your attention.